We're presenting on the topic locked in. Presenting Miss R, a 20-year-old lady who presented with history of a snake falling off the roof onto her face and biting her chin at 7:30 p.m. on 27th of September. Within the next 30 minutes, she had 3 episodes of non-projectile, non-bilious, non-bloodstained vomiting, and she was not able to keep her eyes open. She was taken to a nearby government hospital where she became drowsy, and then she was referred to Government Medical College. And in Government Medical College, she was intubated in view of respiratory distress and was given 10 vials of ASV and then referred to CMC. They did not notice any localized swelling or ulceration over the site of bite, and she did not have any bleeding manifestations. On examination, the patient was unarousable with a GCS of 2T by 15. Her vitals pulse rate was 148 beats per minute. BP was 150 by 90 millimeter mercury. She was afebrile and she had a saturation of 98%. On examination of the central nervous system, her pupils were bilaterally 3 millimeter, initially sluggishly reactive in emergency, and by the time she was shifted to ICU, they were non-reactive. Dorsal reflex was absent. There was no facial asymmetry. Power on examination was 0/5 in all 4 limbs with hypotonia. Deep tendon reflexes were bilaterally absent in upper limbs and lower limbs. Plantars were bilaterally mute. Other system examinations, cardiovascular system, S1, S2 were heard and no added sounds or murmurs. Respiratory system, bilateral normal vesicular breath sounds were heard. And for abdomens, to soft, non-tender, and no palpable organomegaly. She was given 10 more vials of ASV in CMC and shifted to ICU. During the course of ICU stay, she persisted to have low sensorium with a GCS of 2T by 15 even after 96 hours of admission. The differentials that we thought of were hypoxic ischemic encephalopathy due to the initial respiratory distress and hypoxia to the brain, a CVA that she could have developed, a metabolic encephalopathy, prolonged envenomation, neurotoxic bite, septic encephalopathy, and or drug-induced encephalopathy. On investigating her hemoglobin was 10.6, total counts were 13,000, platelets of 343,000. Her electrolyte sodium was initially 130 millimoles per liter. Potassium was initially 2.8, which was corrected to 3.6. Calcium was 7.6 milligram per deciliter and was corrected to 9. Magnesium was 1.76. Phosphorus was 31. Hepatic and renal functions were within normal limits. MRI showed diffuse cerebral. 2 sequential MRIs were done, which showed diffuse cerebral edema and features of raised ICT. Blood cultures were sterile, and chest X-ray showed a normal study. In view of her prolonged decreased sensorium with no other localizing symptoms, a prolonged neurotoxicity in a neurotoxic envenomation was considered. In India, common crate and cobra are the common neuroparalytic snakes. Despite severe neuroparalysis with ASV and ventilator supports, patients usually recover completely. They also develop autonomic dysregulation, which causes tachycardia, labile hypertension, and mydriasis. Neurotoxic paralysis in snake bites, particularly crate bites, there are 2 types of toxins, alpha and beta Bangara toxins. Alpha toxins act preferentially on the postsynaptic membrane, which causes irreversible blockage of binding of acetylcholine to the nicotinic acetylcholine receptors. Beta Bangara toxin, however, has an enzymatic activity of phospholipase A2 activity, which causes presynaptic depletion of synaptic vesicles and destruction of the presynaptic membrane. I would like to talk about 2 case reports. This first one, Fight of Lee, which was done in Chennai by Gunashree Kadalvelu, describes an 18-year-old young male who had a crate bite. He had flaccid quadriparesis with bilateral ptosis, external ophthalmoplegia, and pupillary reflex sagitally reacting to light. He was in an unarousable coma for 4 days, following which he had a gradual recovery, and even on day 19, he had residual deficits. The second one was a study done in Sri Lanka where 210 farmers who were bitten by common crate were followed up for 3 years, and among them, 141 developed severe envenomation and it required mechanical ventilation, which lasted either from 12 hours to even 29 days. However, most of them required around 2 days of mechanical ventilation. The last one, this case study described a 35-year-old gentleman who was in a state mimic locked-in state for 96 hours and before showing a gradual recovery after grade bite. Miss R was in a locked-in state for around 96 hours after admission. On day 5, she started slow improvement, and by day 7, she had a GCS of 20/15. Currently, her mechanical ventilation has been tapered, and she's on BiPAP ventilation. Learning points: prolonged neurotoxicity is an entity that can be seen in common crate bites. It can mimic brain death with absent brainstem reflexes also. They may require prolonged ventilation and recovery will be gradual. Thank you.
But a classical history of snake bite with a complete classic quadriparesis of some cases. What is the first differential?
The differential for it's not about for what the diagnosis was, why she did not why her sensorium and why her neurological status did not improve after 4 days of this thing, even after 20 vials of ASV.
Expect that 3 to 4 days of time.
She recovered in 4 days. She recovered by 7 days. By day 5, she should. No.
Do you think that this is more prolonged than how it used to be? No. The recovery here was longer than it
because persistently her GCS was 2T/15 for around 5 days.
Quite common. Why do you think
the blockage is irreversible and ASV, if given late vein.
How is it reversible? What is the mechanism of neuromuscular therapy?
The alpha toxin prevents the acetylcholine from acetylcholine to the nicotinic acetyl receptor postsynaptically.
That is not correct. Causes irreversible damage of the nerve filaments. It causes the acetylcholine will not get released at all. So in fact, electron studies have shown that there is irreversible, not reversible. There is damage, physical damage to the nerve terminal as well. Because it is phospholipase, it's an enzyme that degrades the receptor. And it takes time for the nerve to regenerate and even the acetylcholine vesicles to regenerate. That's why it is taking time. Of course, depending on the amount of venom that is injected, depending on how early was the ASV given, how much of damage was done, the recovery period can vary between days to weeks. But taking 5 days may not be very uncommon. Maybe it may come across to us as uncommon because we don't see so many things.